Good morning. First of all, to practice, I apologize for speaking in English, but I don't know French. And second, I would like to thank the organization in particular, Professor Luis Miguel Gutiérrez for having invited me presenting this topic. What I'm going to present are mainly the results of a task force, a meeting that we had in Toulouse, in France, last year. And after a very long work, long discussion, we finally got this joint publication in Journal of Frailty and Aging and Journal of Sarcopenia and Muscle. I'm going to provide you the main topics of these discussions, and I'm also trying to provide you some insights that are not written in the paper, but might be of interest for better understanding this very interesting and hot topic for geriatrics, geriatric medicine, and gerontology. I think that some of you have already seen this guy. This is a psychiatrist, American psychiatrist, and this picture was taken at the end of the 90s to show how physical exercise, even at old age, was really beneficial. And so we have this almost 70 years old person that is training really a lot and has a very good, well-shaped body. What is less known is the second picture that was taken to this guy 10 years later that has not been so commercialized. And after 10 years, the guy was still active in a relatively good shape, but it was the modifications due to the aging process were evident on his body. And so we see that the body is less shaped than before. Maybe he gains some fat and the muscle is reduced, possibly also the function of the muscle. And I think that picture is really capturing the inner message that was proposed by Rosenberg when he first proposed the use of sarcopenia. This is mainly the paragraph that is describing how the term sarcopenia was born. And during a meeting on age-related diseases, he pointed out that maybe the skeletal muscle decline is the more striking phenomenon of aging, and so proposed to adopt it to study the aging process and also to define a very specific domain of research. And he talked here about sarcopenia as the decline, the age-related decline of mass, but that was also responsible for the decline of function, exposing the person at risk of negative events. Sarcopenia, since then, has received a real boost in research, and now we can say that sarcopenia is a phenomenon that is common to every human being, every living being, including worms. In this slide, you can see the results of this study performed in Chernobyl elegans, where you can see that the young worm has more muscle compared to the older one, and also the structure of the wall, the muscular wall, is quite different. So we are seeing here the effects of aging even in animal models. And in humans, this does not change. Sarcopenia has been described as a condition that is really imposing major modifications in body composition and function. So this is quite evident here, where the imaging of the thigh of a young person, it has more muscle and less fat compared to the imaging of an older person. And there is also a decrease over time of the metabolic metabolic rate of the muscle with age. In the meeting in Toulouse, we tried to work a lot on what are the good markers of sarcopenia. Since sarcopenia is accepted as a condition that is relevant in the aging process, and maybe has also consequences under more relevant clinical aspects, it is important to understand how to define, how to capture this phenomenon. So we started talking about what is a biomarker. This is really the crude definition of a biomarker. A biomarker is defined as a characteristic that is objectively measured. So the objectivity is one of the major issues. And is a characteristic that is evaluated as an indicator of a normal biological process, pathogenic process, or pharmacological response to a therapeutic intervention. So objectively we measure something to get an estimate of something that is ongoing. So the biomarker is needed. I am a geriatrician as a background, so I use every day in the clinical practice biomarkers to define diagnosis, to facilitate the tracking of changes over time, and also to help the decision process in the clinical setting. And in the meeting in Toulouse, but even more generally, a biomarker can be a functional measure as well as a biomorphological marker or a imaging-related parameter. So it's a very broad definition. Sarcopenia, unfortunately, is not so straightforward. Something like the Fragility syndrome that we heard before. And the concept of sarcopenia has growingly become more and more complicated over time. The first study was the end of the 90s, so it's less than 20 years that we are working on this topic, and the novelty is still arriving, the novelties that modify current evidence. In this review, this very nice review, Beaufort provided the inner structure of the biological processes underlying the sarcopenia phenomenon. And I think that is quite interesting that he put in the same column sarcopenia, dyspnea, and activity limitations. So in this study, in this graph, it is evident that the muscle has multiple components in it. Trying to translate a biological concept into clinical practice, we need definitions that can be operationalized in the clinical setting. And one of the issues that we are currently dealing in the field of sarcopenia is the existence of multiple definitions, multiple operative definitions. We reported in the study the 4 main definitions that are currently available, and our definition, each one is derived from consensus meetings, from international task force of experts. It is interesting that none of them is agreeing with the others for what concerns the position of the cut points and the adoption of the definition criteria. But I think that is more important to know the pros of this definition that are providing the concept of the bidimensionality of the sarcopenia phenomenon. Because differently from the first studies on the skeletal muscle decline, current definitions, these definitions of sarcopenia are combining the quantitative evaluation of the muscle mass, that is the amount of mass that a person has, with a concept of quality. In most cases, gait speed or measures of muscle strength. And this was mainly the rationale underlying this decision was to parallel the diagnosis of sarcopenia to other diagnoses that are used currently in the clinical setting. For example, the Alzheimer's disease. The Alzheimer's disease is based on neuroimaging as well as on tests of cognitive function. In the sarcopenia field, there was this kind of parallelism. The evaluation of a quantity of mass, of muscle mass, in relationship with the assessment of muscle quality, differently defined according to function. The problem in these last years start arriving when how to define, especially the quality of the muscle. Because if it is quite straightforward how I can measure the muscle mass, because it's quite objective. I mean, a person may have a certain kilos of mass, of muscle. So I need just the measure that is better capturing this amount of quantity. The quality makes give us more problems, because the concept of quality can be interpreted in different ways. And the first studies start showing us that maybe quality is more important in determining the onset of negative health-related events compared to the poor measure of muscle mass. In this study by Cesari, it was evident as both in men and women, the mid-thigh muscle area, so a very accurate measure of the muscle made by CT scan, was not predictive of disability, that is the main outcome for geriatric medicine, differently from the knee extension strength, so a measure of quality, and also the mid-thigh muscle attenuation, that is an indirect measure of muscle quality, because it captures the intramuscular infiltrates of fat. So this study start making us think that maybe muscle is not so relevant, the amount of muscle is not so relevant in the determination of events, but other factors, strength and fat mass, might be to better consider in this domain. And there is also the problem with the definition of this two-dimensional sarcopenia, that they are not declining at the same rate with the aging process, but that's shown in the Chianti study. The decline of muscle strength is different from muscle power, another measure of muscle quality, and is also different from the relative stability of quantitative measures of muscle mass. So we are trying to put together different concepts in the same definitions, but each concept is driving the results differently. It is for sure that the muscle is declining, but it is also evident that there is a shift in the body composition, so that with age there is an increase of fat mass and a parallel reduction of muscle mass. And this is evident, as we saw before, both in the quantity of the muscle in a young person compared to the muscle of an older person, as well as in the amount of fat that is beside the muscle, but also inside the muscle. So sarcopenia starts getting more and more complex, because there are more factors that should be taken into account in the definition of this skeletal muscle decline. And this other study is supporting again this idea, showing that over 5 years, these data are from a 5-year follow-up, the area of the quadriceps measured with I think to remember this was MRI, was relatively stable, independently of the gain of or loss of weight, compared to muscle torque, so a measure of quality, in both men and women. And in the same way, it was shown that the subcutaneous fat tissue was relatively stable in men and women compared to the intramuscular fat infiltrates. So even the fat mass is not the same, and it is differently affecting changes over time. Going back to the biomarkers, so this was to show us the complexity of the phenomenon of sarcopenia. Going back to the definition of biomarkers, that was the main topic of the meeting in Toulouse. The biomarker, maybe the definition of one single biomarker, the identification of a biomarker as well comprehensive for the concept of sarcopenia may not be possible, because we may have different biomarkers, each one for the different stage of evaluation of the skeletal muscle decline that we need to adopt in our research. We may have biomarkers that are good for inclusion or exclusion criteria, other biomarkers that may be more accurate and more correct to use in the baseline evaluation of persons, and also biomarkers of sarcopenia that may define endpoints. And when we talk about endpoints, I talk about clinical relevant endpoints, because if we want to translate the sarcopenia from the